So hi, good afternoon, everyone. Welcome to our Emerging Infections, Monkeypox and Beyond webinar. I will be, just quickly before we introduce our speakers, I'll be giving some instructions on our interpretation. So if you look at the bottom of your screen, you should see a globe, an icon on the bottom of your screen. You can switch over to the channel for the language, whether that's Chinese or Spanish, and then you'll be able to lower or mute the original audio for you to be able to hear the interpretation for the language you chose. And then just quickly, some webinar etiquette. Please keep yourself on mute to reduce background noise or any distractions during this webinar. If you have any questions, you can use the hand raise feature or the chat box. And then we will address some questions at the end of our webinar. And this is a recorded webinar. And I'll hand it over to Karen.
Yes, hi. My name is Karen Bonnick, and I'm the co-director, along with Joanne Siegel, of the Rose F. Kennedy University Center of Excellence in Developmental Disabilities. If you've never heard of them, our acronym is UCED, and we're located at Einstein College of Medicine, Montefiore Medical Center. For those of you not familiar with UCEDs, we're part of a national network of about 70 university-affiliated centers that conduct research, training, and community education related to developmental disabilities. Today's event is supported by a grant to our UCED from the New York State Department of Health, Children and Youth with Special Healthcare Needs Program, or SHIN. And through the SHIN project, we're partnering with New York State's two other UCEDs to work with the state's 58 county health department to provide technical assistance and community education and programming such as today's event. So as the school year rolled around, we increasingly heard from our downstate families in particular that they had questions and concerns about monkeypox. So today we're pleased to introduce, as you see on the screen, Dr. Margaret Aldrich, who is the director of the Pediatric Infection Control and Epidemiology at Children's Hospital Montefiore and assistant professor of pediatrics at Montefiore Einstein. Her clinical focus is on general pediatrics infectious diseases, and she has an interest in travel medicine, maternal child transmission of infectious disease, and transitional care of HIV into adulthood. As well as a discussant, we have Dr. Vincent Siasoco, who is our UCED's Director of Clinical Services. He is a family physician whose clinical and training interests focus on persons with DD, developmental disabilities. He holds committee leadership positions with the state's Office for People with Developmental Disabilities, as well as in Special Olympics and numerous other groups. He will be on hand after Dr. Aldrich finishes speaking to address any DD specific issues. So with that, I will pass the talk on to Dr. Aldrich.
Thank you so much, Karen, for that introduction. I am really happy to join you all today. I feel very passionately about all the things that we're going to touch on today, and I'm really happy to be here with you and to be a resource for you and the community that you serve. Just wanted to mention that I am doing some epidemiology research funded by Merck Pharmaceuticals. So I do have some experience with RSV in hospitalized children, but that is not really relevant to today's talk. Next slide. So we're going to talk a little bit. I know that there have been questions coming up about monkeypox, and I'd like a chance to share some of our latest knowledge on this topic with the community. We will speak a little bit about monkeypox, and we will be able to answer questions. I will to the best of my ability. I really also want to talk about a few other emerging and maybe old viral infections that we are all familiar with that are kind of presenting themselves to our communities. at this time. So we will also talk about a few other viral infections that I feel from my perspective are important for the community to be aware about. And then finally, we'll touch on some strategies to stay healthy for ourselves and for our children. So the background that I sort of want everybody on this call to think about before we even talk about monkeypox, I want you to think about kind of how the world around us affects the infectious diseases that we are presented with. And the Centers for Disease Control and Prevention has a program called the One Health Program, which is available for people to look at online to read a little bit more about. And it's a program that really tries to look at the changing environment and the changing world around us, and how that many different factors kind of contribute to the infections that our communities are faced with. So in the background of the infections we're going to talk about today, I want people to remember that humans have been faced with infectious diseases for thousands of years, and that the way we treat our environment, specifically now with issues around climate change and deforestation, we are changing the habitats of animals that live in the environment with humans. And when we do that, there is concern that some of the infectious diseases that previously may have only been in isolation, in communities, really in animal populations that were not affected by humans, we are seeing more frequently animal infections that are transitioning to human populations. And some of that, I think we have to acknowledge, is due to human activity. And we should really think about that, study that, and try to make sure that we acknowledge and make changes wherever we can to prevent that from continuing, especially, kind of running out of control, because that, I think, for all of us will be a problem going forward. Next slide. So into that context, I want you to think about this new viral infection that has been called monkeypox, okay? This is actually a virus that was first identified in monkeys, and it is related to a very well-known virus called smallpox virus, which has been known to affect humans for thousands of years. But this newer virus is much less transmissible, and it does cause less severe disease than the smallpox virus. Many people across the world who were born before 1972 are actually vaccinated against smallpox. So, if you were born before 1972, or perhaps you were born in another country that did smallpox vaccines until the late 1970s, then you likely have protection against smallpox, which thankfully is not an active infection in people right now. But the good news about that is that you very likely have protection against monkeypox, because the smallpox vaccine probably gives you some immunity against the virus that we're calling monkeypox. So a lot of people in the United States and across the world probably have some protection against monkeypox because of their prior vaccination. Now, for those on the call who were born after 1972, or if you have children who, are obviously born after 1972, they would not have been vaccinated against smallpox. I would like to reassure you, though, that that doesn't mean that they're automatically at risk for getting monkeypox. And we'll go into that in a few slides. Monkeypox, in terms of the history, before 2022, most cases of monkeypox in people were identified in Central and Western Africa. And these cases were really likely related to what I mentioned before, the animal and human environmental exposures, where people were living in close contact with animals that had this virus. In May of 2022, we started to see cases of monkeypox really outside of the area where we generally have identified cases. So that is the outbreak that we are talking about today. And that is viral transmission that has really affected many parts of the world, including Europe and the United States and the Middle East. And it is a strain of monkeypox virus that is a little bit different than the more severe strains that are seen in Central Africa. Next slide. So how is monkeypox spread? How do you get it? And basically what we're finding, at least with the newer strain that is responsible for the increased infections in New York and around the United States, we're really seeing that you really have to have very close contact in order to get this strain of monkeypox. So we're talking about skin to skin, we're talking about intimate contact, sexual encounters. There is concern for contact with contaminated surfaces, but I think most of the data shows that it really has to be probably more than, contact with surfaces. While that is something we do have concerns about, the vast majority of cases are really shown to be very, very close contact. Symptoms of monkeypox can include fever, sore throat, swelling of the lymph nodes, often in the neck, in the groin, muscle aches, headache, rash. And the rash is really the symptom that I think most people have heard about. And as a doctor, that's the symptom that we really look for if we're worried about monkeypox in a patient. So the rash is really important to this particular outbreak. And the rash can have a lot of different appearances. It can look like pimples, it can look like blisters, sometimes it looks like sores. It could be painful or itchy, or both. At one point it's painful and then it becomes itchy as it heals. It's going to go through different stages. And I think that's really important for people to understand. If you wake up in the morning and you have a pimple on your cheek, that's not necessarily monkeypox, okay? We don't just take a rash by itself. You have to think about the whole history and the whole picture and what happens to that pimple over time. If it is, like any pimple that you have, if you're a teenager or you have a teen child and they have a pimple, that's probably just a pimple. But if it's changing over time and there might be some other risk factors, then that's something you would definitely want to talk about with your doctor. Sometimes these rashes can look like very common childhood illnesses, like what we describe as hand, foot, and mouth disease. HFMD is how we shorten that. Herpes virus, which is very common and causes cold sores around the mouth and possibly causes genital sores. Varicella virus, which is what we commonly know as chickenpox. And finally, molluscum contagiosum, which is also a very common viral illness that many children will get. And it is not dangerous, but it can cause little skin rash that can look a lot like some of the rash associated with monkeypox. Next slide, please. So these are some photos that are taken from some of our medical literature. And these are pictures of common rash that is associated with monkeypox. And what I really want folks to look at is if you look at the bottom photos, the letters F, G, H, and I want everyone to appreciate that the rash of monkeypox changes over time. So at the very beginning, it might look like a small, flat, red area with a little bit of something in the middle. And then over time, they develop into more fluid-filled blisters, and those eventually crust over. We worry about spreading the virus until that rash, that bump, becomes dry and crusted. So the picture on the bottom, all the way over to the right, where it says after 9 days, that is an example of a crusted monkeypox lesion that now is less likely to be a source to spread monkeypox because it's really nice and dry. Monkeypox is a virus that spreads when you contact the fluid in that little blister. It can also be when you contact, body fluids as well. That's why it really takes very close contact, at least from what we are understanding from this latest outbreak. It's close contact and exposure to the rash fluids or exposure to some body fluids. Next slide. These are some other rash illnesses in children. These are not images of monkeypox. So, and these are publicly available images. I just want to point out the upper left images are hand, foot, and mouth disease, a very common illness in children, especially in the summer and autumn. So this time of year, we see a lot more of hand, foot, and mouth. And it's often associated with a virus called Coxsackie virus. The image directly above the text is an image of molluscum contagiosum. And these look like little pimples with a little hole in the center. And they are also very common in children. Finally, the bottom left pictures are images that are examples of varicella zoster, which is the virus that we call chickenpox. That's what it causes. It causes chickenpox. So this would be sort of your classic chickenpox rash. And that is going to show different little pimples at different stages of healing. So monkeypox, typically you'll have all pimples, all crust, all at the same time. With varicella or chickenpox, you might have one that's a pimple, one that's crusted, one that's just a red spot, and that's going to happen at different times. Next slide. So this is, I think, maybe my most important slide for everybody to have access to. Even if you don't read through it to great detail, I think it's really important for people to remember that we need to put ourselves in the context of this infection. So we always have to think about, yes, there is a virus. Yes, it's circulating in our community. We need to look at the risk factors for being somebody who's going to have that virus. So the Centers for Disease Control and Prevention and the New York City and New York State Department of Health have very clear criteria to help people like me as a practicing pediatrician, help me figure out if I have a patient come in with a rash, do I need to worry about monkeypox? So typically we look at the epidemiology around that patient or child or adult, depending on the case. And in this case with monkeypox, yes, we need to see some symptoms like the rash that we talked about, but we also need to see that there is something else that leads us towards monkeypox, okay? We've already stated that in young children, you're much more likely to have an enterovirus, a Coxsackie virus, a common childhood virus causing one of these rashes than you are to have monkeypox. But things to make you think of monkeypox would be if you know there's someone in the household that lives with the child or the young adult and has monkeypox, that's going to be a higher risk, okay? If you know that this is a young person who is sexually active in the community, okay, they might be at higher risk because we are seeing that this is predominantly a sexually transmitted infection at this point. If you know that somebody has traveled to an area where there has been monkeypox reported for years, such as Central or Western Africa, and you know that they've been in contact with more rural areas where they could have been in contact with animals that could have this virus. Or obviously anyone you know has had actual contact with wild animals. You know, they might work in research or they might have that as their livelihood, or a new pet that's coming from a place overseas. So these are all things to highlight whether or not you should think about monkeypox when you see a particular rash or you worry about, could my child have this infection? The other important thing, especially in pediatric patients, is thinking about what is an alternative explanation for the rash, right? Because, you know, like we already mentioned, several common pediatric illnesses can cause these kinds of rashes. And so that's also really important. And then there's always thinking about the timeline. Monkeypox typically will have a rash, and it should be, the timeline should be consistent with the expected timeline of development of exposure to the rash. If a patient or a child has a rash and is tested and their testing is negative, then we worry much less about this rash really being monkeypox. And thankfully, at this point, we have fairly good testing available to us across the United States, for sure in New York. Actually, I shouldn't say the rest of the country. I don't practice there. I practice here in New York, but I know that we have testing really readily available to make sure that that's not, you know, the cause of the rash. Next slide. And this is to help people further kind of put this outbreak in context. So these are some data that are shared publicly on the CDC website and really showing that the case counts. Please be aware that we prepared these slides about 10 days ago. So this data is as of September 20th and September 14th for the table. But I just want to point out that as of September 20th, we have 24,203 confirmed cases of monkeypox orthopox virus, which is the more scientific descriptor for the infection. And the map of the United States that is shown here shows you that the darkest blue areas, those states, so New York, Pennsylvania, Illinois, California, Texas, Florida, Georgia, and Washington State, those are all cases with the highest reported number of cases, so more than 500. And anyone living in New York or the tri-state area knows that we have definitely seen cases in New York and been really, once again, an epicenter for this outbreak. On the table, I have highlighted with the red rectangle the total number of pediatric cases under age 15. So maybe a little unsurprisingly, young people ages 16 to 25 have seen cases of monkeypox. And again, I don't have the specific details of each of those cases, but for the most part, we assume that those cases are related to sexually transmitted infection. Whereas in younger patients, in younger children, you can see there are many, many fewer children under age 15 who have confirmed monkeypox across the United States. So I believe the count here is 28 children under 15 out of 24,203 confirmed across the country. And for the most part, these are going to be children who were having very close contact in a home setting with somebody who then tested positive for monkeypox. Next slide, please. This is a line graph here, and this is showing you the case counts in New York City. So this is just New York City data, the 5 boroughs, and it's as of September 16th. And I want to just highlight for the group that we have had 3,356 confirmed cases of monkeypox. 2 children have been identified under age 17, and 205 cases in the 18 to 24 year age group. I do want to highlight the good news of this data is that you can see that the graph is curving downwards, meaning that over time we are certainly seeing, as of sort of the beginning of August, we might have reached our peak in New York. Our numbers for confirmed cases in New York are really coming down. So by the middle of September, we really are at a much lower case count across the city, which is great news in terms of what is the chance that my child or my patient or my young adult is going to have this viral infection. If the community transmission is lower, then we see lower rates of positive cases. Next slide. So I'm going to go in the interest of time. I'm seeing that we are now halfway through the hour. I'm just going to quickly review a case that was presented in the CDC's Morbidity and Mortality Weekly Report. And this is a case of an infant who was diagnosed with monkeypox in Florida. And I want to highlight this case to give everyone on the call a little bit of context, especially around pediatric monkeypox in the United States, and sort of help people have some sense of what we're seeing. So August 2022, there was a report of an infant with confirmed monkeypox in Florida. The infant initially presented with a red rash on the arms, legs, and body that they had for 5 days. Common viral infections, such as the ones that we've talked about on this call, including varicella or chickenpox, herpes simplex virus, and HIV, were all negative for this infant. The child was otherwise well enough at the time of initial presentation and was sent home with supportive care. Unfortunately, the baby returned 2 days later with a rash that now looked a little bit more like fluid-filled pimples that were developing what we call a central umbilication, which is like a little dip in the middle of the pimple. The baby was admitted for IV hydration with a diagnosis of molluscum contagiosum, which we also talked about, and I showed photos in an earlier slide. The lesion spread and became pustular, prompting testing for orthopox virus, which, as we mentioned, is the family of viruses that monkeypox comes from. Next slide. So 10 days after the rash began, the PCR test, that's the polymerase chain reaction. Since COVID, I think everybody has heard the word PCR before. So this is a PCR test that's specifically for this monkeypox virus that is connected to the outbreak we are seeing in New York. And the test was positive for the baby. The baby was treated in the hospital with an oral medication called tecovirimat and was also given vaccinia immune globulin. And that's a special medicine that gives the baby antibodies to fight the viral infection. The baby was given eye drops to protect their eyes from scarring from the rash because it had spread to the face and the eyelids. And the baby clinically did very well with therapy and made a full recovery and was discharged home per report. Next slide. So the public health department in Florida had to do a detailed investigation about this baby and how did this baby get monkeypox. And when they reviewed the household, they came to find that most likely the exposure for this baby was from a very close contact within the household. There was no history of childcare outside the home. There was no history of travel. There were 4 caregivers in the home. And based on the report from the health department, the infant was in daily close contact, skin to skin, with many of these household members. They were family members and they were holding the baby, and it was summertime, it was hot. Everybody was trying to keep cool, and there was very likely skin to skin contact. In addition, there was bed sharing between the infant and 1 or 2 of the household contacts. The caregiver in the home, one of them reported that they had actually had symptoms, including fever and rash and blood in the urine, what we call hematuria, within 3 weeks prior to the infant's symptom onset. This caregiver subsequently was tested and tested positive for orthopox virus, monkeypox. The 3 other caregivers in the household were given post-exposure vaccination, and they did not develop monkeypox. Next slide. This is a graph from the MMWR article, and it's just showing you the infant patient, the caregivers A, B, C, and D. And caregiver B is the caregiver that it is presumed was the source for the infant. I think one of the important take-home points of this picture is that with post-exposure vaccination, the other adults in the home did not get sick, even though there may have been very close contact between caregiver A, C, and D with both the baby and the other caregiver B who tested positive. So this goes to show that with careful monitoring of close contacts and post-exposure prophylaxis, including vaccination where appropriate, that we are really able to reduce the risk of ongoing spread within a household or within a community. Next slide. So important to know that one of the major lessons we've learned with this latest outbreak is that this particular strain of monkeypox and the way that it has presented has really posed many issues are really around supportive care of folks who develop the rash. And a lot of that actually has to do with pain, because the rash can be very, very painful, and it can present in sensitive areas of the body where if there's swelling, it can be extremely uncomfortable. So pain control has actually been a really important part of management of this infection. In addition, thankfully, we do have a medication, which the baby in our case received. It's called tecovirimat. We commonly call it TPOX. I think that's kind of a cool name and easy to remember, TPOX. And that is really indicated for a range of different patients. So a young child under the age of 8, we might be concerned they're going to have more severe disease. So they would be somebody who might be referred, and we would recommend that they get treated. People who are immunocompromised or have medical complex medical conditions where we worry they could develop a pneumonia or some other sequelae or issues around the infection. If the infection is in a sensitive area like the face or the genital area where scarring could cause problems, or if somebody we know has real skin issues like very severe eczema, or they have an underlying medical condition that causes their skin to peel, they may be at risk for more severe disease. And that's a person who might also need to get TPOX treatment. And that medication is twice a day for 5 days, and its oral medication is available. Vaccination, the vaccine that we are most commonly using now, is manufactured in Scandinavia, and it's called the Jynneos vaccine. And generally, that is not going to be a vaccine that every child gets with their routine checkup. That is going to be a vaccine that we really reserve for those who are highest risk individuals, or they are individuals in, for example, a household where somebody has monkeypox. In that case, they're high risk of potentially being exposed. And so they may be somebody that would be referred for vaccination. Next slide. So I believe this might be my last monkeypox slide. And what I really want folks to do is keep these take-home messages. This is a palm card, an information card from the New York City Department of Health around ways to protect oneself or one's family from monkeypox. And I think really sort of your basic common sense things are included here, which includes making sure you do your best to practice good hand hygiene, shared bedding and towels, launder them regularly. If you or your child, adolescent, or young adult child is sexually active, be sure to talk about safe sex practices and make sure that safe sex practices are easy and available for the young people in your lives who are sexually active. Recognize some of the symptoms, recognize the epidemiology, the risk factors that we talked about, disinfection of contaminated surfaces, routine cleaning of the environment should be adequate, and make sure that kids and adults alike are staying up to date on their routine vaccinations. Because if you're not up to date on your routine vaccinations and you get sick, it becomes confusing. Is it varicella chickenpox? Well, if you're fully vaccinated, it's less likely to be chickenpox. But if you're not vaccinated, then it leaves some question and makes it harder to figure out what we need to worry about. Next slide. So with that note, I just have a few slides left, and we have about 15 minutes. I'm looking at the clock. So I just want to take a few minutes to update the group on a few other viral illnesses which as a pediatrician, I think are equally, if not more important for the community that cares for young people should really be aware of. And the first one is a health alert that was sent out to providers at the beginning of September from the CDC and supported by the New York State Department of Health regarding a severe respiratory infection that is circulating across the country and is associated with either rhinovirus, which we typically think of as a common cold virus, or enterovirus, which is more often we think of associated with potentially a diarrheal illness. It can also cause that hand, foot, and mouth with the skin lesions. But there's a particular strain of enterovirus that we tend to see every 2 years. And so this year, 2022, is one of the years we expected to see increased circulation of enterovirus D68. And sure enough, right now we are seeing more kids being admitted to the hospital with a pretty bad respiratory illness that maybe they need to be in the hospital for a few days, get some support for their respiratory status. And we are finding that some of those young people have enterovirus infection. Some are rhinovirus, some are enterovirus, but we are seeing more activity with this particular viral entity. And I wanted people to be aware of it. There's no treatment for it. It's really more supportive care and doing things like good hand hygiene, making sure that if your child isn't feeling well, probably okay to keep them home for a few days until they're feeling better. Obviously, we still always worry about COVID, so doing a few COVID tests to make sure that it's not COVID. And then definitely, you know your kids the best, knowing when they need to seek additional medical care and being aware of this circulating in the community. It can be associated with a kind of flaccid paralysis called AFM, but that is much rarer. And to be very honest, in our practice in the last 2 months or so, I have not really seen AFM present. I've seen more severe respiratory illness. Next slide. On the note of flaccid myelitis or paralysis, I have to mention for the group, as has been reported in the public media, we have identified polio circulating throughout the tri-state area in Rockland, Orange, Sullivan, New York City, and Nassau counties. And this was sparked by a case of a young adult who was not vaccinated against polio and presented with paralysis, or what we call paralytic polio. And this prompted investigation by the New York State Department of Health, which then led to Governor Hochul declaring a state disaster emergency in order to mobilize vaccination and surveillance efforts and to cut transmission of this potentially very severe viral infection. It is important to note that vaccine prevents the most severe paralytic polio. So vaccine is a very important tool that we have to prevent children from becoming severely affected by polio. And the vaccination rates, and that is looking at children 3 years and under across the state, because children will get, by age 2, will usually have 3 doses of vaccine, which is giving about 99% protection to get 3 doses. It is standard for children at age 4, before they go to elementary school, to get a 4th dose, almost like a booster to fulfill the series. And that completes their protection. But it's important to note that the 3 doses that are part of the standard under 2 vaccine series are very protective. The problem is we do not have 100% vaccine uptake. Vaccination rate is really over 90%. That is what is needed to prevent disease. And we are seeing vaccine rates between 58% in Orange County, that's one of our lowest, to 79% in Nassau County. Adult healthcare providers also might be recommended to get a booster, an adult one-time booster dose, if they could be in a position where they're caring for higher risk kids or adults. Next slide, please. So this is just a graphic of New York City, the 5 boroughs, and the darker blue indicates greater than 99% vaccine coverage. So you can see there are areas in Staten Island and Brooklyn and part of Queens that are very, very light blue. And that suggests that those neighborhoods have less than 70% vaccination rate in young children, 6 months to 5 years. Up in the Bronx, we're doing a little better. Definitely parts of Manhattan have very high vaccine rates. I think all of us who work in public health and epidemiology would love to see this whole map of New York City be a dark, dark blue. But we have some work to do on that front. Next slide. Finally, my last infection that I wanted to bring up to everybody on the call is the influenza season that we expect for the year 2022-2023. The WHO, which is the World Health Organization, monitors worldwide reporting of influenza-like illness. And this has been going on for decades, well, at least, several decades now. But we in New York often look to the activity in Australia or South America or South Africa because their winter is our summer and our winter is their summer. So their winter is when they have flu season. They have just gone through it in July, August, and September. And so we look to their rates of influenza to give us an idea of what our winter influenza season is going to look like. And I'm sad to tell everyone on this call that they have had one of the worst influenza seasons this year, maybe one of the worst in 10 years or so, at least in the last 5. So I'm a little concerned that this winter we're going to have pretty intense influenza activity. And I will share with the next slide, I can show you sort of a graph that shows that. This red line jumps right out at you. That is the 2022 influenza activity in Australia. And the other lines show you past years. So 2017 is the dark blue, purple is 2019. During COVID in 2020 and 2021, influenza was almost non-existent, and that was the case in New York as well. But this year you can see influenza is making up for lost time as it appears in Australia. So that makes us worry a little bit about what is on the horizon for us here in New York. Next slide. This indicates the variant. As you know, influenza has several subtypes, and I'll just go to the next slide. So my last slide is just to encourage everyone that remind you that you do have some control. And I know being a parent and taking care of kids can sometimes feel like you don't really have a lot of control over things. But vaccination actually is something that we can all do. We have control over this. We can get our vaccines and we can make sure we are up to date. And that is a really important tool that we have to fight a lot of these viral infections that are coming our way. So really importantly, I think everybody on this call should be sure they get their influenza vaccine for this season. I really encourage you to be sure your children are appropriately vaccinated against the flu and against COVID. I will say in my practice, I see a lot of families that are fine to get their own COVID vaccine as an adult, but they are hesitant to vaccinate their children. And I would really encourage people to really think strongly about making sure that children also are fully vaccinated against COVID, and to speak to their pediatrician or their primary care about what that means and the timeline for those vaccines. But COVID vaccination series is really standard of care at this point, and we really do recommend it for all children, especially kids who might have some medical complex issues themselves. Ensure that your child is up to date on their polio vaccine. Make sure that if you need to get extra information, recognize that your local Department of Health and your center, our CDC, have really great patient and parent information on their websites about everything I've talked about today. And then finally, I do want to give a shout out to all my pediatric and primary care colleagues, because they really are a phenomenal resource for everyone on this call. And they are, they really care about their patients, they advocate for their patients, and they really have their patients' best interests at heart. And I think they are a great resource if you have questions or concerns about vaccination. And with that, I'm going to close and give it over to Vincent to join or to help answer some of your questions. Thank you so much for your time today.
Thank you so much, Dr. Aldrich. Vincent, I don't know, Dr. Siasoco, is there something you'd like to say before we just get to the few questions that we do have? We only have 3 questions.
Yeah, well, first of all, I want to thank Dr. Aldrich for a wonderful presentation. It was very informative. I think one of the challenges with monkeypox and the DD population is that, unfortunately, there's not a lot of research out there in terms of how it affects this population. So more needs to be done to look into that. I think a couple of takeaways from Dr. Aldrich that was very important is that if somebody presents with a rash, they don't just look at the rash. We have to get more information to the provider so they can make an accurate diagnosis, what the context is, what's the history, what information is available, so that when they do see the provider, all that information will be at hand. And also preventative care. It's very important to get your vaccines in a timely manner at your annual visit with your pediatrician or your adult primary care provider to make sure that you're up to date on that.
Thank you. So just a few questions. One of them is, if a child lives with an infected family member, what is the incubation period before symptoms first appear?
So there is some variation in that. Typically what we do is, generally I should be full disclosure, it's not me, it's usually the local health department would take this on. But what they'll do is they will risk assess the home, and then they will potentially offer post-exposure prophylaxis to anyone in the household. Could include children. And that, like I showed in the case, should prevent ongoing transmission in the home. If for some reason the other contacts in the home cannot get post-exposure prophylaxis, then the waiting period is up to 21 days. So typically, I think it would be sooner than that, within 5 days to 7 days, that you might expect some symptoms, but we technically have to watch for symptoms for 21 days from the last point of contact.
Thank you. There's a Spanish question in here. Miriam, I'm wondering, are you able to read that?
Is in reference to shingles. I don't know quite if she's asking about the child's age or Monica, do you want to go ahead and unmute and ask your question?
Sí, buenas tardes. Yo tengo una inquietud. A mí me dio varicela cuando tenía como 13 o 14 años. A la edad de 57 me dio un poco de culebrilla. Me pusieron la vacuna pero yo he oído en niños que tienen culebrillas. Si no han tenido varicela, ¿cómo pueden tener culebrillas?
Okay, so she's asking if children are able to get shingles if they didn't have chickenpox.
Generally, shingles only occurs in individuals who have had the actual infection, chickenpox, at some point, or very, very rarely, if a child is vaccinated against chickenpox, they had their standard vaccines, and they usually, it's if they also have another immunocompromised, medical condition, they may develop a shingles rash, that zoster, that sort of painful zoster rash. That is very rare. Even having a child get shingles is rare. It really is much more common in adults, middle age, or adults under periods of stress, then it can happen. But it's not, we don't see shingles unless there's been some varicella before, because shingles is a reactivation of the virus.
Thank you. And before I get to the last question, I would just like to point everyone to the chat. There are links to the English and Spanish sort of rating. That is not quite the right word, but if you could just let us know what you thought of the talk, we'd really appreciate. The last question, I think, was really interesting, and I think it does go to your first slide, Dr. Aldrich. When you mentioned earlier about cross-infection with animal viruses, is that for those who raise animals for food, like the live markets? Can you explain more? And this gets into that environmental piece that I think is so important that you raised.
Yeah, so I mean, I don't think it's been such an issue here with this particular outbreak of orthopox virus or monkeypox virus, but it certainly has been an issue with other viral infections. And I think that we had an outbreak of monkeypox in, I think it was 2003 in Wisconsin. It was the upper Midwest. There were a handful of cases of monkeypox, and that was related to importation of a small rodent animal that was being sold from West Africa to the US specialty pet market. And there was actually an outbreak of monkeypox from that transmission, from bringing up an animal and selling it as a pet in the United States. And so I think that the cases of this particular virus, or going down the line, another animal virus, I think that when we are in close contact with animals, whether it be from the live markets or specialty pet kind of animal, and sending animals from one part of the world to another, that does, it's a potential risk, it's a potential exposure. Is that going to be kind of every outbreak starts that way? I have no way of knowing that, but I do think we need to be aware that there are some things that are circulating in animal populations that, we haven't been exposed to, and we don't have immunity for. It's not a human pathogen. And so being mindful of that, I think, is important.
Thank you so much. So everyone, please just take a moment. It really helps us if you could just grab that, link in the chat and complete the survey. And I want to thank our speaker. This was really informative, really, really nicely done. I would like to thank the interpreters and the staff who helped put this on, the technical assistance. So I know we've kept everyone a few minutes longer, but just grab the link, please. And we will be sharing the slides and the recording after. So thank you. Thanks, everybody.
Thank you.